when they enter their dialysis chair for 5 to 6 hours, 3 days per week, every week of the year, for the rest of their lives.
The winner of the 2019 Big Idea Challenge is
the Deluxe Medical Chair.
The big idea I presented, we won, so we thought, what more can we do for them? And the chair was the answer. And the $45,000 prize money was just the stimulus we needed to be able to engage the design engineers. And to get us underway, we've provided some additional funds, but it really takes that to get an idea like this to a prototype stage. At a work function, Teresa Anderson happened to be standing next to a chap from Design and Industry, who are an industrial design firm in Rozelle. And we thrashed out, using the feedback from our patients and our nurses and our own ideas, what a chair might look like. And now, 2 years later, much work down the track, we've actually landed a prototype in this country that isn't quite there, but shows huge potential, and I think it really will make a difference to the lives of a lot of our dialysis patients. If we could crack 2% or 5% or maybe even 10% of that market, that could be a really important quality lift for those patients, but also a potential source of revenue for our hospital and our country. Once we're at prototype stage, I've got great hopes that we can move into manufacturing and produce chairs that are the best in the world, not only for our patients in our unit, but for other patients in the hospital. People in infusion centres, haematology, oncology spend a lot of time in chairs like this, and we've got a better chair. This will work in those situations. So that's where we're going.
Good afternoon and congratulations before I start on Steve Chadban, the winner of the 2019 Big Idea competition, who joins us this afternoon. He's been elevated to judging now. So nice work, Steve, and good work on the chair. Welcome everyone to Sydney Local Health District's The Big Idea for 2022. I'm Bernie Hobbs and I am rapt to be your MC for the afternoon. I'd like to start by acknowledging the Gadigal people of the Eora Nation and pay my respects to the elders past and present. And I'd also like to convey apologies from Dr. Teresa Anderson, the Chief Executive of the district, who is at home with COVID, and we all wish you a speedy recovery, Teresa. Now, as many of you know, not just from how interested she was, hooking up with people at that event to get you the industrial designer on board, but Teresa is a very big fan of the Big Idea. She actually started the Big Idea a decade ago, partly as a way to celebrate and kickstart great new ideas in health innovation, and partly because she was a total Dragon's Den fangirl. So she made her dream come true. I was more of a fan of that other show, not Dragon's Den. What was it called? Oh yeah, The New Inventors. Had some really great judges on that. Instead of having Teresa this afternoon, we're going to have Dr. Andrew Hallahan, the Executive Director, Medical Services and Clinical Governance and Risk, stepping in on her behalf. So I do want to acknowledge our key invitees this afternoon, board members of the district, partners, sponsors, community members and staff and delegates from the district, New South Wales Health and beyond. So as with this other sessions in the innovation program, we're being live streamed here. So welcome to everyone joining us remotely, and we are being filmed and recorded, and there'll be photos taken throughout the afternoon as well. Housekeeping, exits out the back, bathrooms the way that you came in. After afternoon tea, I'm sure you're very familiar with that. Please maintain your social distancing and COVID measures, and if you need any help, we've got plenty of staff around. So the Big Idea is going to be bookended by two fantastic presentations. No pressure to our two presenters. But we've got presentation, and then we've got our 5 Big Ideas contenders sitting here quite nervously, but looking like they're holding it all together, which is a good sign, getting ready to pitch to you and to the judges. So that's coming up soon, and then we'll have another presentation after that before we find out who is the winner of the big idea. So our first presentation, sticking very much on theme, the Sydney Biomedical Accelerator, revolutionising the science of healthcare. And our presenter is Professor Robin Ward, the Executive Dean and Pro Vice Chancellor at the Faculty of Medicine and Health at the University of Sydney. Robin's an academic leader, career researcher and clinician who's made significant contributions to health policy and practice in Australia, as well as to the higher education sector. No, come on, Robin, otherwise I'm just going to embarrass you reading that ridiculous list of achievements that you've got in your life. So please join me in welcoming Professor Robin Ward.
So it's great to be here, and I'm just ever so slightly sad that Teresa isn't here with me, because Teresa and I were going to do this presentation together. We'd had it all sorted over who was doing what slides, etc. So now I'm going to do Teresa's bit as well. But the Sydney Biomedical Accelerator really is something that Teresa and I have been working on together over the last, it seems like an eternity, but I think it's really only the last couple of years, but it has been a long journey. So this is really built on a partnership that the University of Sydney and the Sydney Local Health District has had for more than 140 years. And over the last 140 years, lots of milestones have happened. Various medical research institutes have been formed, and I see those institutes represented here in the audience. But by and large, the organisations have worked together with a single-minded purpose around training clinicians, training health professionals, training scientists together, and trying to make a difference in healthcare by using that partnership in a very strategic way. And all of those things have led to lots of great outcomes over the last 140 years, which is a very long time. So we have all these ingredients that we thought really make us a very globally relevant health and innovation precinct. The recent developments around RPA, in particular the $750 million to build a new hospital, is a real milestone and a real injection of funds into a much needed revamping of the facilities at RPA. We've built together over that period core research programs and core facilities that we all share. We have strong leadership, we've got trials networks, we've got a great environment around us with Tech Central developing and a whole lot of things happening around us, but we felt always that there was this one missing piece in the puzzle, and that was really state-of-the-art laboratories and facilities that would really allow us to connect our very best and brightest scientists in the precinct with the clinicians and vice versa. This whole idea of bench-to-bedside medicine and back again, which does sound hackneyed but is still pretty relevant today. I think everyone would aspire to that goal. So our aspiration in bringing together this idea of the Sydney Biomedical Accelerator was to attract even more fantastic people than are already here. We already know we have lots of fantastic people, but could we bring more to Sydney and particularly to the Camperdown precinct? Could we increase our collaborative partnerships with industry? Because we know industry are new partners of health and universities. We're not really where we would like to be in terms of our industry partnerships, so could we energise that? Could we actually accelerate the rate of translation from science into clinical practice? Everyone is frustrated by how long it seemingly takes to get from a discovery on the bench to something that someone can use every day in their clinical practice. So is this a way of doing this? And could we actually use all the clinical data that's generated at RPA once again to ensure that our scientists are focused on the problems that really matter in healthcare, whether they're the problems we face today or the problems that we will face 20 or 40 years from now? So we're very strategically located in this Tech Central precinct. As you've read in the newspapers, there's a lot happening now around the Tech Central precinct. The precinct is coming alive with both other universities, UTS, with what's happening at Everleigh Rail Yards, with all of the activities around Tech Central. And so we're now in a position where Tech Central can really be the sort of IT end of the precinct, and the upper end of the precinct that is around Camperdown can be really the life sciences and medical precinct. And what an amazing precinct that would be, something that we could be internationally known for. So this is buildings, just the buildings are required to do the laboratory work and to do the science we want to do. So you can see on the diagram there the Royal Prince Alfred Hospital. A is labelled as Gloucester House with the jacaranda in the middle. Building B is an application we have into government to consider investing in Building C. And the university has made a commitment to build Building C already. And the SWHB is the Susan Wakel Health Building, which is the largest now health training facility in the country. And they're now trained all within the Faculty of Medicine and Health, which trains about 13,500 medicine and health students a year now. So that's the total cohort of students. It's the largest training facility now in the country for health and medicine. And it is obviously very well known in terms of its capacities in research as well. So we're progressing the development of the precinct already. Building A is already being planned and underway in terms of the renovations inside Gloucester House. As I said, the University of Sydney has already approved the construction of Building C, and a lot of work is underway at the moment now. It's a design competition out at the moment around what this whole precinct would look like, and a lot of work is underway around cleaning the land of all the things that are left on the land after people have been building buildings full of other things we don't talk about anymore. So all of that is happening, and then the land will be able to be then built on. As you see by this diagram, this will be the first time that the University of Sydney and RPA are actually physically connected. We will be able to walk completely undercover without getting wet from RPA into the university, into the Susan Wakel Health Building, back into the hospital and around about without ever having to leave the undercover of the buildings. So that'll be a fantastic place to work. The university and the LHD have together and separately done all sorts of amazing things. You heard about Steve's invention and the prize that he won a few years ago, and that's going absolutely amazingly. Tony Weiss and his work on elastogen is absolutely an incredible invention, really transforming many aspects of healthcare. Perks was another chance encounter between Teresa. I don't know whether it was chance or whether the inventors sort of mowed down Teresa in the lift one day, but anyway, she likes to call it a chance encounter. But whatever, they came up with a great app that looks at how patients can be better empowered to actually control and manage their own health problems, particularly where there's multiple problems going on at once. So another fantastic innovation. And finally, engineering new solutions for cardiovascular disease, again led by Steve Wise, who's an engineer and scientist in the Faculty of Medicine and Health, in partnership with Michael N.G., who's a cardiologist, and those two working together on what is a very, very exciting and already being used field, which is the increasing use of interventions to fix heart problems that previously would have required surgeons to deal with. And so obviously that's great for a patient, great for patient outcomes, and it's wonderful to see these next generation of devices, implantable devices and devices which can be implanted and then removed, being used to address cardiovascular problems which previously would have required complex surgery with all the associated morbidity. So that's a great team working together on those things. Okay, so we've got lots planned for what we're going to do in this building. I'm not going to go through all of these things here, but really what we're trying to do through this, through the accelerator, is really accelerate all the amazing things that are happening both at the university and at the hospital and with industry and with our MRI partners and with everyone else who wants to come and work here. This is an open door, it's not a closed shop by any means. What we're trying to do is to attract people to come and work in an amazing health and innovation precinct. So with that, I'll thank you. Again, apologies from Teresa. I won't tell you which of the slides she was doing and which was I was doing. Please don't report back if I muffed up any of her slides. But hopefully you've got a good idea now of what the Sydney Biomedical Accelerator is about. And if you want to see more, just log on to that website.
Sorry, Robin, I thought we were going to roll straight onto a video from there, but what an astounding level of achievements you've already had, and the buildings aren't even finished being built yet. Isn't it amazing what those CADs can do to make something like Gloucester House look like it's come off Grand Design though? Because I've been there and no. Yes, Jacaranda maybe, but the rest of it. So congratulations on that. I will just check, are we going with the video? Yep, okay, we're just going to... we already saw the where are we now for the chair, and now we're looking at the where are we now for Shaheen Hazmat's inaugural People's Choice winner, because there are two prizes up this afternoon. The winner of the big pitch and the People's Choice. So we're just going to have a look at the standard set in 2019 for the inaugural People's Choice winner. Thanks.
So the winner of People's Choice Award is Dr. Shaheen Hazmat for Blink.
Blink is an implantable solution that is aimed at restoring movement in facial paralysis, and specifically restoring eye closure. So facial paralysis, for those who experience it and those who treat it, know very well it's a very debilitating condition. Priority is protecting the eye because you lose the ability to blink or close the eye. I think with a project like this, it's about being in the right place at the right time. I think the big idea was that kickstart we needed. The concept had matured to the point where we were ready to implant it in a live model to see if it actually is even feasible. And we needed a lot of funding to be able to do that. So for that, we had to generate a lot of data, a lot of preliminary data. And that's where the Big Idea Fund really gives that kickstart. In addition to the funds, there was obviously a lot of help in terms of exposure to the scientific community. Link is a very novel concept. We find interest in the science of it, but a lot of us, I think, like myself, I didn't appreciate how difficult it is to get your idea into reality. There's a lot of mechanics between the two, and science by itself, unfortunately, will not be enough to get you across. So getting the right people to help you get through that journey, if you ultimately want your idea to benefit your patients, you'll need the right support to get there. As the device matured, it needed more expert input, and we needed those funds to be able to support the work of people like Jacinta to carry on the project development of the device. And so she now herself and the rest of the biomedical engineering team are leading the front on maturing or developing the device for improved biocompatibility and improved functionality.
Since I've been involved in the project, we've turned the Blink device from a concept into a physical device. We've got it to the point where we have a device and it can create the action that we need it to be able to create a blink. I've also been developing software over the COVID lockdown where we can record the eye blink and we can start to do things like identify when a blink happens and also compare a natural blink to a blink that's caused by the device. Obviously that's very important because we want to make sure that whatever blink is created by the device is as natural as possible so that we can restore blinking to what the person experienced before they had this kind of injury or illness that caused their facial paralysis.
My advice for people applying for the Big Idea would be, number one, get your data ready. Number two, in terms of preparing the application, capture the value that you're trying to create with your project. And for that, it's important that you clearly explain and express what the problem is that you're trying to address. And finally, your language has to be clear and effective.
And congratulations again to Shaheen, and what an astounding advance they've seen in those few years, going from idea to prototype and being able to start testing it and developing the software. It's just terrific. Not too late to heed Shaheen's advice on how to do well in the pitch this afternoon, but I feel like you've already nailed that first bit because you made it through that huge swathe of entries to be a finalist this afternoon. So just to reiterate, the big idea is a Sydney Research, Innovation and Commercialisation Challenge, and it will support individuals like Shaheen and Steve to progress their idea to the next level within their organisation. The idea can be anything: a device, a prosthetic, a chair, a marker, an app, a treatment, a piece of technology, a process or a system. If it has the potential to be developed into a commercially viable package to transform healthcare or research, it could be the next big idea. So I've been mentioning our 5 finalists. I want you, before you do anything else, to just give it up to these 5 who have already been culled from a bunch of very high calibre applications, and they're going to present to you as well as to our expert panel, who I'll introduce in just a moment. And it's important that they present to you because you're going to be voting for one of the prizes, the People's Choice, at the end of all of those 5 pitches. So make sure you really listen and think about what could have the greatest impact from where you sit. It may be different from what the judges come up with. So the 5 members of the judging panel who are going to fight it out, sight unseen, in a distant room: Dr. Andrew Hallahan, Executive Director, Medical Services and Clinical Governance and Risk at the District; Professor Robin Ward, who we just heard from, so I'm not going to introduce her again, but totally; Dr. Gavin Recchia, Principal of Davies Collison Cave, Patent Attorneys; Ms Anne O'Neill, Director of Enterprise and International Partnerships at the Office for Health and Medical Research, and she's told me she's willing to, spill blood to get her way in the judgment this afternoon, so she's the judge to watch. And finally, our big idea winner from 2019, Professor Steve Chadban, so bringing that experience to the fore, what he knows now, 3 years later. So I'll just reiterate, the finalists are pitching their ideas for their chance to win $45,000 pre-seed funding, which is very generously provided by Sydney Local Health District and the University of Sydney, as well as $25,000 worth of IDE services, which will help you to reach the next stage of commercialising your idea. So that's a fantastic prize of both funding, cash and in kind. And the Big Idea 22 also will see the People's Choice Award, where the audience, you, will vote the winner, who will receive $5,000 worth of IDE services. And importantly, both winners, the Big Idea winner and the People's Choice winner, will receive from Cicada Innovations a place in their incubator program, which is a fantastic way to get a leg up on developing that idea. So you'll be provided with support around market sounding and developing a business plan. Okay, the rules are pretty straightforward. Each presenter has 5 minutes, and I will ring a bell at... Actually, sorry, Christine, do you mind? I'll just get the board member to hand me a bell, because that's how much power I wield up here. So it is literally, when you hear the tiny little jingle, that's 1 minute to go, okay? And when you hear the full on, it won't stop until you stop. That's it, your time is up. Don't go over, because we will be deducting points, both the People's Choice and the formal judges. So keep it at the 5, nice tight 5, please. And I do want to apologise to St Patrick's School, Melbourne, who they've been waiting to go out for lunch all day. So thanks very much, St Pat's, for letting us have the bell there. Okay, so we've got the 5 minutes. So once we've gone through each presenter, we'll have their 5 minutes, and then our panel of judges here have 3 minutes to ask questions. So we'll have microphones coming to you, so please stay up front for the 3 minutes of answering the judges' questions. And then we'll move on to our next one. So it's going to be very rapid fire. After all 5 finalists have pitched their fantastic ideas, we're going to shoot the judges out that way, or I should say escort the judges out to their judging location of choice. And we're going to have, that's your chance to vote via Slido, and I'll explain all that a little bit later on. Okay, so you'll have 5 minutes to do the People's Choice. So you can argue with people around you and try and convince them if one of your mates is doing the pitch, if that's the way you roll. But otherwise, you know, just do your normal vote. Are we ready to go? How are we feeling? Okay. Oh, don't have that look. Yeah, no, you've got to be more G'd up than that. Okay, our first finalist, we are ready. Are the judges ready? Okay, all right, good. Judge away. Okay, we have got, and is my timer, Mariam, ready to go? Okay, so we're about to start the timer as soon as you start speaking, so please give a very warm welcome to our first speaker, Dr. Joe Dusseldorp. Cheers. Whoops, sorry, that was a false start.
Hello, my name is Dr. Joe Dusseldorp, and I'm a plastic and reconstructive surgeon working at the Chris O'Brien Lifehouse, Concord Hospital, RPA Institute of Academic Surgery, and at the University of Sydney as well. What I'm here to talk to you today about is a revolutionary new medical device that's going to help us to reimagine what it could be like to live with disability. But first, I want you to think about, have you ever really thought about what it takes to send a text message? It's something that we do every day, all of us without even thinking about it. Some of us hundreds of times. A couple of you are probably doing it right now. But have you really thought about what goes on inside the human body that enables us to do that? Or have you looked at a teenager sending a text and ever just thought, wow, like what's going on with those thumbs? And so what is actually going on is a complex series of connections from the brain through the nervous system to the muscles in the exquisitely precise order and sequence to enable those flurry of movements that sends a perfect text. But what if there's a breakdown in that communication channel at the brain or at the spinal cord level? It leads to a series of changes at the muscular level that causes conditions like cerebral palsy, the #1 leading cause of physical disability in our children. It's accountable for 17 million people worldwide, and not only affects the muscles of the hands and thumbs, but also the legs, affecting the ability to walk, and often leading to people being relegated to wheelchairs. Of the 1 in 500 children born with cerebral palsy still, over 1 in 3 people will never walk. And that's despite spending about $1 million in 2003 data on treatment throughout the course of these patients' lives. We use botulinum toxin, we use selective dorsal rhizotomy surgery, which cuts nerves and cuts tendons to try and make these limbs work better, but the reality is none of these treatments really improve quality of life. And so as a reconstructive surgeon, I spend most of my days looking at the tiniest of little nerve branches that travel all throughout our nervous system, intricately working their way to exactly the muscles that need to work. And there's nothing wrong with these nerves. There's actually nothing wrong with the muscles to begin with. And so if we take away the reliance on this nervous system and we just go directly to that nervous system that's perfectly designed from whoever designed it, I'm not sure about that question, but we can get to all of those nerves, they're just under the skin, and we can do it in a minimally invasive way. The problem is we actually have to think small to be able to do that. We need to be able to build a medical device smaller than any neural stimulator that's ever existed. The good news, the technology to do that exists, and I'm proud to be leading a team of biomedical engineers that are helping me to do this as we speak. The two men here, Professor Alistair McEwen is the Chair of Innovation at the Cerebral Palsy Alliance in the University of Sydney in the Faculty of Biomedical Engineering. And he has a great wealth of experience in what cerebral palsy patients want, and that's leading this research. John Paul McEwen works with Ingenuity and ResMed, has a wealth of experience in building medical devices, and he is my Chief Technical Officer that's helping me to make this first prototype. It was actually New South Wales Health and Cicada Innovations that propelled me down this path when I did the medical device commercialised training program, now the health training program. And that was in 2018, it led us to form a company to be able to do this properly, because what we learned from that is we actually want a medical device to come out of this, it needs to be a commercial effort. We've had the medical device partnering program from Flinders University support our program, and we've also now partnered with Neobionica, who is the commercial arm of the Bionics Institute in Melbourne. And I'd love to talk to you, Robin, about what's going on in my local network. So we've characterised this unmet patient need. We know we've gone through the detailed prototyping. We know what the device needs to be able to achieve. And where we're at is looking at how can our medical device prototype actually be put into an animal model. And that's where $45,000 would really help, as well as having our IDE partner to be able to build the wearable device that has to accompany our implanted medical device. Just like you to reflect on the fact that the World Health Organization estimates 1 in 7 people live with chronic disability of some form. That is disability that affects the whole body, not just the motor nerves and the sensory nerves, but a raft of other conditions we could treat. And while you're sitting there today, reflect on the fact that what other activities do you take for granted? And use those perfectly functioning thumbs of yours to vote for Synchronicity. Thank you very much.
Nice work. See, if you hadn't name-dropped Robin in there, you would have had time to just end perfectly. But no, you took the extra 2 seconds to suck up to a judge. Yeah, that's ingenuity, if ever I've seen it. Now, we have exactly 3 minutes for your questions. We have a microphone with the judging panel. Yes, okay, please fire away. Oh, and we're just, yep, that'll come up as you speak. Don't touch it.
Sounds amazing, Joe. Are you going to enable people to text, or are you looking to lose spasticity from arms?
Yeah, there'll be a phased approach. The first step is to relieve the tightness in the muscles. So essentially switching off the nerves is actually the first step. But we then have demonstrated in some early animal studies that we can then control the distal muscle. We can actually make the muscle fire independently after that.
Great. Next question.
So with the prototype, what do you think needs to be done to getting from the prototype to the final product? Is it going to be additional features or further miniaturisation, or both?
Yeah, so the initial prototype won't be miniaturised. We have to demonstrate proof of concept and effectiveness before we can spend all of that R&D in the actual miniaturisation. We know what features we need to miniaturise, but it's really about power. How much power do we need to be dealing with these really distal nerves? And no medical device has ever tried that. So all medical devices up to this point, pacemakers, cochlear implants, they're dealing with big nerves. We're talking about tiny nerves. So we potentially need much less power, but we need to actually get into the animal models and start to delineate that.
Next. Yep.
So can you tell us more about which animal models are used for this sort of testing?
There's terrible animal models for spasticity, unfortunately. So we created an animal model in a rodent with a spinalized rodent that could have an actual spastic hind limb, but it's very low fidelity. So it's a lot to put a lot of animals through to get very few. You can't do large animal models for spasticity because it would require like an intensive care unit for essentially what we do for children with cerebral palsy. So we don't do that with animals. Animals have to be able to walk and feed themselves to large animals to be able to be kept alive after a brain injury. So it's, we don't have good animal models, which is why we need to go to clinical data pretty quickly. And we've identified the operations clinically that we can go into where nerves are being cut anyway, which is where we'll go. As soon as we have the device ready in a prototype fashion, we'll go to those surgeries and test before those nerves are cut, which is the current standard of care.
Wow. Clever. We've got 1 minute left for questions.
You just led into my next question.
Oh, sorry, do you mind removing your mask?
Oh, sorry, I always do that. 2 clinical trials, have you already mapped that pathway? Have you already thought about what that's going to look like and who you're going to bring on to help you with it? That, of course, is going to be a huge undertaking, just so that you get the right data sets to go forward.
Yeah, absolutely. We have clinical partners and research partners. I didn't have enough time to really go into all of it today, but I think there's our hand surgery colleagues who really deal with a lot of the spasticity patients that will be kind of leading the clinical part of the program. I myself sort of stand outside that, but really oversee the medical device development phase. But we have those partners already ready to go.
Maybe one quick one. Extension of the application beyond cerebral palsy or not?
Absolutely. I think they're our kind of evangelists, if you use the medical device term, in terms of there's a very mobilised group of parents that are looking for technological solutions. They already have databases of all these patients, who put their hands up for clinical trials. So that's our first port of call, but spinal cord injury, stroke, lots of others.
Come on, mate. That's it. You've had your turn. Good job. Well done. Thank you very much. Thank you so much. That's setting a very high standard first up, not just with the device, but also sticking to time. We love a hard 5 minutes here. So you've heard one of our finalists. We're ready for finalist number 2. With no further ado, please join me in welcoming Dr. Anthony Katrupi, and a sympathy vote for Anthony, who's struggling with what looks like a skiing injury at this stage. So, but clearly not.
Human beings, by their very nature, are dynamic, forward-moving creatures. We change over time, and as we change, part of that process is that we age. And as we age, our cells in our bodies gradually lose their ability to repair themselves. We take longer to heal, and we heal less efficiently. If only we could go back in time to capture the regenerative properties our cells possess in our youth, then we could use this as an antidote to the treatment of traumatic injuries. Well, we can do that. We can defy the nature of time, and we can send our cells back in time to a point where they behave like they did in our youths. And we can use these cells to help us manage and treat traumatic injuries such as burn injuries. Over 10,000 Australians each year are hospitalised due to severe burn injuries. And what's more, a staggering 11 million people globally are impacted by severe burn injuries each year and require hospitalisation. Those who are fortunate enough to live through their injuries are sadly plagued by the psychological and functional burden of disfigurement associated with scarring. Current treatment of burn injury involves transplanting healthy skin onto affected areas, but this is merely a shortcut, sacrificing reconstruction of the skin for patient survival and immediate wound closure at the cost of permanent scarring. And herein lies a crucial and unmet need in the treatment and management of traumatic injuries such as burns. Our solution to this is simple: to leverage the restorative and regenerative properties of youthful skin. It grows quicker, it heals faster, and it does so with less permanent scarring. And we can do this by sending your cells back in time so they reacquire this power. Think of it as cellular time travel. And we can do this by using the scientifically proven and established methodologies involved in cellular reprogramming. Turn back the clock too much and we get embryonic stem cells. And although the age of these cells is completely reset to day 0, they don't resemble skin anymore and they cannot be applied clinically. If we turn back the clock too little, our skin cells won't rejuvenate. However, if we turn back the clock just the right amount, by partially reprogramming, we can rejuvenate skin cells up to 30 years and perhaps even more. And we can combine these cells with current surgical practice, improving the clinical and post-operative outcomes of patients, and ultimately revolutionising individualised medicine and the treatment and management of any wound, whether chronic, traumatic, surgical or cosmetic. So currently, the market has a product called RECELL, which is colloquially known as spray-on skin. And this really began a rethinking in the traditional wound closure treatment methods, and it's just an alternative to relocating healthy skin to an area of need. And the way it works is we can take a skin biopsy from a patient, from a healthy site, we can isolate the skin cells and spray them back onto the wound, and we can do this in a one-stage procedure using a relatively simple kit. Our product, ladies and gentlemen, represents a quantum leap forward in the setting of tissue regeneration, cell relocation and wound healing, adding a fourth dimension by being able to travel back in time. The product we're proposing to create will enable us to do much the same things as RECELL, however, improves upon it dramatically by giving us the capacity to use regenerated and rejuvenated human tissue. And this opens up the possibility of potentially scarless healing. So the team that will be working on this project is unmatched, and we bring together globally recognised expertise in cellular reprogramming and skin cell maintenance and clinical management. Combining the Burns and Reconstructive Surgery Group headed by Professor Mates with the Northcott Neuroscience Laboratory headed by Professor Kennison, as well as the close relationship that we have with the largest and the best burn skin unit in the country. And this academic synergy will really drive project success and propel the progression from bench to bedside. So in order to do this, what we are asking for is $45,000 in order to create our kit. And using this kit, we will be able to rejuvenate human skin that is personalised to each individual based on their age and based on their skin type. So we may not be able to change the past, but we can actually go back and capture the power it hides in our youth, and we can bring it into the present, and we can use it to improve the lives of millions of people across the world suffering from traumatic, chronic, surgical or cosmetic wounds. Thank you very much.
Look, I don't want to be influencing your vote, but did you see how Anthony came in just under 5 minutes? That was stunning. Also, 55-year-old skin becoming 25-year-old skin. If it works for 57-year-olds, I'm backing you, man. Congratulations on that presentation, and we're now ready for our questions from the judges. Yeah,
I might just jump in. Thank you so much.
No
one question is, what do you have right now?
So at the moment, we're in the process of collecting the skin biopsies. We really need the numbers in order to really test the efficacy of this. We know from the scientific literature that this is very much possible. It has been done. It's just not been applied to the wound healing context. So what we're in the process at the moment is collecting the skin biopsies. That's an expensive process, and then trying to optimise the rejuvenation procedures so that they are getting maximal rejuvenation with the minimal amount of time.
Andrew?
Simple question. Children get burns and they've got young skin, as well as old people. How much difference is there really in the healing between, in burns therapy, between a, say, young person / teenager and a older 50-plus-year-old?
So we know from the literature that wound healing begins scarless, right, as a fetus, and as we change in age, our propensity to scar increases. So this is going to have a great impact for elderly people, particularly people with chronic wounds, where they've had wounds present for a long time, and that's going to help the healing process because we know that rejuvenated skin behaves, or has a less propensity to scar than we know older skin does.
Once you've identified the factors and the parameters you need to adjust to turn back the clock just the right amount, you said it has to be personalised. How much time do you envisage it takes then to personalise to each individual?
So at this point, we're thinking around 3 to 5 years to actually get all this up and running and to be able to test this. What we're going to be aiming for is a single process, but that process is going to have different effects on different individuals based on their skin cell and their skin type and their age. But what we are aiming to do is to try for each of those groups achieve maximal rejuvenation in a limited window of time so it can be applied clinically.
Do you have any sense if it's days, weeks?
In terms of?
Hours of getting the rejuvenated, reprogrammed cells onto the site?
So well, a lot of this is still to be, sorted out, and we can't really disclose much, but we know we're looking at a window of between 10 to 14 days for rejuvenation, and then after that point we'd be applying those cells and then trying to achieve wound closure and wound healing.
Anthony, ex vivo manipulation of cells, taking them out of the body into a lab, manipulating them, it is an incredibly broadly practiced science globally. How much competition have you got? So
there are multiple startups in the United States using rejuvenation biotech. None of them are actually applying this process to wound healing. So they all have we're unique in that respect. We're looking at wound healing. The other companies are looking at other aspects of the disease process or injury.
Great, thank you. I'm sorry if anyone missed out on a question there, but thank you very much, Anthony. Terrific and well handled. What happened?
I broke my toes.
Oh, broke his toes, not kicking his assistant, correct? Yes, I thought as much. So that's 2 down, 2 exceptional contenders so far, and I'm sure that's what we're going to continue to see in our final 3 presenters. Our next finalist is ready to go, Dr. Robin Ciela. Please join me in welcoming Robin.
Thank you, thanks.
Good job.
Thank you. Hi, I'm Robin. I have been treating lymphedema at Royal Prince Alfred Hospital now for over 15 years. And I absolutely love what I do. I love it because of the impact that we can have on the individuals that we see. Some of you might not have come across the term lymphedema before, but simply put, lymphedema is chronic swelling. It affects about 1 in 200 people. It commonly occurs in the arms or the legs, but it can actually happen in any region of the body. But wherever it is, the impact on the individual is significant. By treating this progressive condition, we not only improve lymphedema, but we can also halve the incidence of recurrent lower limb cellulitis. This is significant because cellulitis is the leading cause of avoidable hospitalisation in New South Wales. Lymphedema changes how the affected region looks and how it feels. It limits clothing and footwear options, and it can even affect mobility, function, and workforce engagement. And it really does affect how the individual feels about themselves. Unfortunately, not all is well in the world of lymphedema. The assessment and care for this condition is time-consuming, with demand far outstripping the resources that are available. In the context of this, every minute of the clinician's time is precious. The frustration which set me on this course was that a quarter of every single appointment is spent on inefficient and unnecessary manual processes. I currently rely on paper forms, mental arithmetic, and a calculator to analyse assessment data, and an array of catalogues in order to prescribe compression wear. Now, compression wear is the mainstay of lymphedema management, and prescription and ordering is really time-consuming. I'd like to give that time back to our patients. And to do this, I'd like to introduce you to Limbase. Limbase is a standalone, cloud-based clinical decision support system that makes better use of the assessment data that we routinely collect. So as well as the efficiencies that it creates, Limbase displays change over time. This is something clinicians, and perhaps more importantly our patients, don't currently have access to. The graphs that Limbase creates tells a story, and it's a story that can engage our patients. It can help our clinical reasoning and support the recommendations that we make. Other benefits include reduced human error, reduced variation between clinicians, and the potential for a world-first learning health environment for this condition. This labour of love began at this very same event 8 years ago when I was awarded a Sydney Research Scholarship, which enabled me to undertake doctoral research looking into data management for lymphedema. I've received further support along the way, and most significant has been from an international compression garment company which has funded the development of the platform. And now I'm back here seeking investment to roll this out into the public health sector. The Limbase team as it stands today is myself and Maithili. Maithili is head of innovation at a data analytics firm, and she's been instrumental in the product development, and she's been instrumental in managing the tech team and speaking their language. In the current business model, Limbase is actually free for clinicians and health services, and it's paid for by the compression garment companies for inclusion in the garment search engine. The research path taken has given me access to an amazing group of experts from the University of Sydney, and they and I have ensured that the path to development has been rigorous, both in design and early evaluation. Now that the platform has been released to clinicians in the private sector, we're ready for implementation in the public sector, and I have a Sydney Health Partners research grant for that purpose. Winning the big idea would allow us to bring this solution to every clinician and patient who needs it across New South Wales, and it would position us for national and even global expansion. Thank you.
Thanks so much, Robin, for coming in 7 seconds ahead of time there. You can donate that to your choice of the remaining presenters, whoever seems in most need, or not. It is a competition after all. Terrific presentation, and while we're just getting over to the judges, I do just want to say, I noted that you said one of the problems is that it relies on mental arithmetic, and then you said that it started 8 years ago when you won the scholarship in 2016.
Yes.
That's 6 years, Robin. So I think it's a very good idea.
It is the reason why I actually started. Yeah.
Please, over to our judging panel.
Thank you for picking that up.
Another maths question. Congratulations on getting corporate sponsorship.
Thank you.
How do you ensure that healthcare providers and patients get even access to products from various producers and not just that one that's sponsoring your outfit?
I've got that.
Yeah, right, yeah.
It's fine. So we still use all of the different compression garment companies. We have catalogues for each one. It's just that there will be a more simple digital search function for the ones that are actually on board. Yeah, so it's not going to exclude anyone.
Doesn't produce a bias?
Look, I don't think so, but I would hope that we have everyone on board so that there definitely is no bias. But yeah, I don't think so.
Yeah.
Hi. Thank you so much. Are you looking at, so it's in this space, I'm sure you've been looking at to see who's who and new in the zoo, and like there are a lot of startups in this, well, the one that I know of, because we funded them through the Medical Devices Fund, but would you be looking at emerging technologies to, for this to include in the database when they're ready?
Yeah, definitely. So there is a bioimpedance machine that we will be integrating with, and we'd look for other opportunities to do that.
Andrew?
Hey, Robin, can you just tell us what this funding will actually do as far as progressing your product? What will you use it specifically for?
Specifically, there are pretty major, and understandably, major regulatory and security requirements for New South Wales Health, and yeah, it would allow us to actually fund that work to be done. It's boring, sorry.
No offence, New South Wales Health.
Yeah, sorry.
In terms of rolling out more broadly then, you talked about sort of, other, maybe it's other states, maybe other countries. Does this have to then tie into the whatever health platforms they use? So is it going to require then a whole lot more funding to take this to another jurisdiction and have it talk to their whatever records, whatever databases they have?
Look, potentially, but certainly we're looking at practice management systems that are international anyway and integrating with them, but it will be country by country. So we would look probably to America first.
And time for one last question if we have one. Nope. All good.
Great.
Congratulations.
Thank you.
Thank you, Robin. So our fourth speaker of 5 here to pitch his idea is Dr. Sam Dowland. Welcome, Sam.
Hi, I'm Dr. Sam Dowland, Head of the Fertility and Contraception Research Group at the University of Sydney. And I'm working on a new non-hormonal contraceptive for women. 100 years ago, if women wanted a non-hormonal contraceptive, what they had to do was to order one of these devices. You have to order it in the mail and, if you can imagine, insert it yourself into your own cervix. Thankfully, this device has been consigned to history. 60 years later, there was development of the copper IUD. However, insertion is still painful and leads to significant side effects, including bleeding and pelvic pain. Here we are now 60 years later, and what non-hormonal options do women have? Still just the copper IUD. All other female contraceptive options, long-acting reversible contraceptive options, rely on administering hormones. But this causes side effects, and I've listed just a few here. This is a $31 billion industry. We can do better than this. These side effects lead to lack of use, and risks unintended pregnancy. And this is a huge global problem. There are 1.9 billion women of reproductive age around the world, all of whom may use contraception at some point. However, there are 121 million unintended pregnancies every year, which is approximately half of all the pregnancies globally each year. This causes huge costs to the individuals in terms of their health, finances and future, and large costs to society and public health systems. So a key priority of the United Nations now is to increase contraceptive options and access to long-acting reversible contraception. And this is what we're working on in my lab. We've got Kirsten here posing for a classic stock photo. And together we've worked on a non-hormonal compound that is shown to completely prevent pregnancy in an animal model. It's represented here by the blue bar, showing in this graph that it is just as effective as the copper IUD, which is there in green. But perhaps most importantly is that this compound works via a completely different mechanism to all other currently available contraceptive options, and this allows us to avoid many of the side effects caused by hormonal contraceptives and the copper IUD. What we're doing now is working on a new delivery mechanism using hydrogels. The benefit of these is that they are soft, flexible and biocompatible, so they can sit in the uterine cavity without causing irritation. And while there, they will slow release our contraceptive compound, providing effective contraception. We're working with women to develop the design of these devices. They've told us in interviews that they really want a new non-hormonal option, and that the key consideration when they're choosing contraception is that choose something that minimises side effects. When asked about our new method, women have said they'd get it as soon as possible. So this is the team that I'm working with. We've got my lab at Sydney Uni across the top. We're working with Professor Kirsten Black, an IUD specialist clinician at RPA, who is also an academic gynaecologist at the University of Sydney. And we're working with biomedical engineers at Udemon Technologies to do some of the hydrogel work. So the big idea would allow us to produce lots of hydrogel prototypes and conduct benchtop testing. We'll then follow the approved regulatory pathway going through animal testing, refinement work, and enter a first-in-world clinical trial. But ultimately, and most importantly, will be to make this new contraceptive available to women and enhance their non-hormonal contraceptive options. And if anyone would like to get in touch and be involved, support the work, or be involved from a manufacturing or regulatory perspective, please let us know. Thank you.
Congratulations, Sam. That was shocking that half of all pregnancies globally are unintended. I thought it was just my high school, but no, that is a very big issue. We're ready for questions from the audience. Oh, sorry, beg your pardon, from the panel, yes?
Hi, thank you for the presentation. Have you got an intellectual property position on either the gel or the material that is released?
Not yet. So once we start doing some of the next steps and produce some prototypes and use the animal model that we've developed to demonstrate their effectiveness, then we would go into pursuing an intellectual property position. Yep.
And is there background IP on the materials you're using?
Some of the materials are proprietary materials, yeah.
So does that limit how you can commercialise?
Well, the company that we're partnered with has the proprietary protection over them, so I think that's okay.
And they're a great company to be working with. I mean, so you picked a really good one in that space. How far will, if you win this, how far will that money take you in that pathway that you just described?
The main focus will really be on that top thing that we listed. So going through lots of the prototyping phase, we will be studying the loading and release of the non-hormonal material, non-hormonal compound from the material. We're doing lots of kinetic analysis to ensure that it will be available at biologically relevant concentrations. We'd love to start some of the animal work. We've got the model optimised, but we'll see how far we can get.
Great. Any other questions? Yep. Oh, just need the microphone. Thanks.
Why won't it fall out?
We've got a few different options. We're going to optimise different shapes and formats of the materials to ensure that it won't just fall out. Some of them can be relatively liquid when inserted, but then solid when in place, and things like that, which, yeah, we'll be looking at some innovations in the insertion mechanism to optimise that.
So is it so you don't have to restrict it to primarily women who've never given birth for that reason?
No, well, that's what we would like to, as we continue through the process, innovate in the insertion mechanism to reduce the pain experienced by people who are getting the current sort of IUD options. So then it would be less painful for people who hadn't given birth, yeah.
In terms of studying release kinetics, how closely can you approximate the intrauterine environment in a dish?
There will be some challenges. We are looking at some synthetic uterine fluid that we'll be using. We can use some Franz diffusion cells to sort of model temperatures and oxygen concentrations and things like that, trying to keep it as closely mimicked as we possibly can. Yeah.
Great.
Thank you.
And we're just perfectly out of time. So thanks very much, Sam. And our final presentation, the person who's had to sit through everyone else and maintain the nerves throughout, please join me in welcoming Professor Niall Wheat.
Imagine you're hiking in the outback of Australia, hours away from the nearest hospital and without mobile phone reception. You're walking down a rocky path and a snake rears up and bites you on the leg. What are you going to do? Every year, more than 1 million people are killed or left permanently disabled by the bite from a venomous animal, including snakes, spiders, jellyfish and scorpions. Now, we live in a world where we have antivenoms for most of these animals. So why are people still dying? Well, it all comes down to access. People either can't get timely access to medicine or they can't get access at all. So the most important factor is that these antivenoms have to be delivered in a hospital by a trained medical team, doctors and nurses. But the antivenoms themselves are protein molecules, which means they're very sensitive to heat and to light. So you need to have established cold trains for transport and storage, and that's simply not feasible in a lot of locations in Australia and throughout the world. Each antivenom is specific for each animal, and in fact the antivenom for the east coast of Australia for the brown snake doesn't work for the brown snake on the west coast of Australia. It's a laborious process to get the antivenoms. We start by farming the animals and milking their venom. We then inject sublethal doses of the venom into horses who develop antibodies. We then siphon that from their blood and purify it ready for human use. And these medicines are incredibly expensive. You can see here the price for one vial in New South Wales for a polyvalent snake venom. So what's my solution? From my research at the University of Sydney, I've developed a potential universal venom antidote, a treatment that anyone could use for any animal, anywhere. So how does it stack up against the current treatments? Well, first of all, my vision is for it to be delivered via an auto-injector-like device. You can keep it safely at home, or you can carry it in your pocket or backpack if you're travelling. The family of molecules it's based on are stable up to 350 degrees Celsius. You could literally leave this in the middle of the Simpson Desert for months and it would still be good to go. While antivenoms are specific for each animal, my one will potentially work for any protein or peptide-based venom. The ingredients are very cheap, $10 to $15 per device. As I said before, the antibodies come from the horses, and serum sickness is a real problem for some patients. Because my molecules are synthetic, the chances of an allergic reaction is much, much lower. and there's no animal welfare issues because they're synthetic. Nowadays, our fur babies are much a part of our family as our real children. There will be so many families that want access to this type of technology if their pets are bitten. Every year in Australia, 300,000 people become parents. Imagine your child is playing in the backyard and they get bitten by a funnel web spider. No parent wants to feel helpless and unprepared when it comes to their child's safety. Imagine you're swimming at the Great Barrier Reef. Wouldn't you feel more secure knowing the surf lifesavers have one of these in their first aid kits? What about schools and ambulances? Imagine you're a farmer in the back paddock and you've been bitten and you've got a long walk back to your house before you can even call for help. And doesn't every soldier out on deployment deserve protection, whether they're in Australia or overseas? The stats you can see up here are just for Australia. Worldwide, the likely demand for this product is going to be huge. Now, it's a long road to get there. TGA approval will not happen within the next 10 years. The big idea funds will be used to continue my research and development into this game-changing technology. But I'm not just interested in money. If you have experience in toxicology or preclinical testing, clinical trials or medical device design, I'd love for you to reach out to me. Thank you very much.
Fantastic. Thanks, Niall. I know a lot of us were distracted by that gif of the, was it a tiger snake? No, what was the one doing, the spitting out the venom?
It could have been, yeah.
Yeah. I feel like you should be on top of which venomous snake is in your talk if you're really going to sell this, but well done you. So that's our 5th finalist. We're ready for questions from our panel.
Niall, having stomped on a stonefish on a remote island a couple of years back, I'm drawn to your product. Will it cross over and neutralise endogenous molecules that I need?
So when I did say all animals, not all animals, so I'll give you a for instance where there are some issues, right? So blue-ringed octopus doesn't have a protein-based venom. It has a small molecule venom that's called tetrodotoxin. My technology is not useful for small molecule venoms and stuff like that. So I'm not sure I can answer the rest of your question without giving away part of the technology, though.
But so you can't say whether it could interfere with other non-toxin molecules in the body?
It potentially could, right? I've put this. I've done in vitro, in vivo, and ex vivo. We've seen no acute symptoms from intraperitoneal, IV, or oral. We haven't done long-term toxicology. It could interact with other proteins, but I can't.
No.
Yeah.
Excellent question. Not allowed to answer commercially in confidence. Next question.
So how would you imagine this would be administered once you got going, and what do you think the shelf life would be?
So, how it's going to be administered, it'll be an auto-injector, and part of the problem that we're going to be facing over the next 15 years is we can't just use a dumb auto-injector like we do for the EpiPen, right? There's no risk going into the thigh. This type of device is going to have to use other parts of the body, and I think we're going to have to develop a smart auto-injector that's going to be able to recognise if it's accidentally going into a part of the body it really shouldn't be doing. So that's going to take a bit of time. What was the second part of the question, Robin? Oh, shelf life. Shelf life. The molecules themselves, you could hit them with a nuclear bomb and they're pretty much fine. The shelf life will really be dictated with how the molecules themselves interact with the device, whether there's any interaction with the plastics or the solvent that we're going to have to dissolve it up in, because we might go with a suspension type formulation or a dissolved solution in water, and it depends on how it interacts with those would dictate shelf life.
I feel like nuclear bombs might peak above 350 Celsius, but you know. And next question.
Can you just describe how far you are down the track of proof of concept that this can be universal against at least all protein venoms?
Yeah, so this actually comes from a product I was actually developing for cancer chemotherapy delivery, and we've repurposed it, so we've actually done quite a bit of work. But what came from, so we've tested it in 3 different types of venoms. One was a simple peptide, one was a single protein, and one was a mixture of proteins and peptides, and it worked for all 3 animals.
All right, and unfortunately that's it for our time in terms of the Q&A, but thanks very much, Niall. And I will now invite our panel of esteemed judges who I have to say ask really good questions. I mean, I used to be a professional judge on a TV show and ours were rubbish compared to yours. So well done you, and I look forward to you bringing that level of vigour, rigour and integrity to your judging process as well, Anne's bloodshed notwithstanding. So please join me in thanking our panel as they exit the room. But this is where it's all down to you, because while we're waiting for our judges to choose who will win the big idea and the $45,000 cash prize plus the in-kind prizes, from IDEA and Cicada Innovations, it's your chance to vote for the people's choice. So on the screen we now have, so to have your say, go to slido.com, #BigIdea. And with your mobile phone, it's going to be open for 5 minutes. So have a good think about who you reckon really appealed to you with their big idea pitch. They're going to be the winner will receive $5,000 of IDE services, and they'll be getting a place in Cicada Innovations Incubator program as well. So that's just 5 minutes. Hopefully you're not having any trouble finding the Slido option. Oh. On the back of? Oh, on the back of your badge that you're wearing as well, there's a QR code. You may have heard of QR codes by now, so feel free to use the QR code instead and make your decision about which of our 5 finalists, Joe Dusseldorp, Anthony Katrupi, Robin Ciula, Sam Dowland or Niall Wheat, which of your 5 presenters will be the People's Choice winner. Do you feel cheapened and shallow by this process? No, good. Yeah, well done. Okay, now, while we're waiting, the judges are going to take a good long while because it's a hefty prize. You can see the giant novelty check over there for $45,000. So there's a lot of rigour going into that decision-making process. So they'll be out for a little while. And we've got 2 things happening during that time. We have a presentation and then we have the presentation of the Sydney Research Awards. Now, when I say we have a presentation, it's a presentation that I have seen an earlier version of this some years ago at another clinical trials showcase in Victoria, and I was blown away by Chris Semsarian's presentation on getting to the heart of sudden death then. So there have been some significant advances, I understand, from that. I hope not. I don't want to have to sit through that thing again. Okay, no. There have been significant advances since then. Chris was a little disappointed. He felt, when he saw the timing of today, he felt like he was being used as the elevator music while the judges were making their decision. That is so not true, Chris. You are a very valued and valid part of this afternoon's presentation. So Chris Semsarian, Professor Chris Semsarian is Professor of Medicine at Sydney Uni, cardiologist and NH&MRC practitioner fellow, with a specific focus in the genetic basis of cardiovascular disease. His research focus area is in investigating and preventing sudden cardiac death in the young, especially children and young adults. Ridiculously successful career, a leader academically, a leader in research, over 350 peer-reviewed journal articles. I mean, that's almost one for every day of the year. And he's also led major community programs in the area of prevention of sudden death. And you are about to be wowed, I guarantee you, by Professor Chris Semsarian's presentation on ending sudden death. Thank you, Chris.
Thanks very much, Bernie. And when Teresa invited me a few weeks ago, I felt really special that it was my research or my excellent clinical program or my good looks or something, and it was none of those. It was just to fill 10 minutes. So I'll do my best to make it as interesting as possible, and thank you to Bernie for the introduction. Thank you. So what I'd like to do is give you a little update in the next 10 minutes. I actually want to just tell you a story about what we're doing in terms of our research into why young people die suddenly, and to understand what Robin was saying before about the Sydney Biomedical Accelerator and bringing our organisations together collaboratively, hopefully I'll show you that how useful that is in terms of progressing our research, and that everything we do with the patient at the centre. And I think listening to these 5 amazing presentations just now made us realise they're all centred on patients and improving their care, and I think that's really important. So this is a bit of a sad slide because it summarises my last 20 years of my life. So this is my area of interest, genetic heart disease. So I like to see young people with heart disease in their teens and their 20s with genetic problems. So my clinics are ABCD clinics, which is anything but coronary disease. So we see genetic conditions, cardiomyopathies, electrical disorders of the heart, etc. And what we try and do is understand what are the genetic causes of these conditions, how do they lead to clinical disease, and how can we then improve the outcomes of these patients? So we learn things about disease mechanisms, we talk about translation, how we translate our research into better diagnosis, better treatment, better outcomes and prognosis. And we do it using a series of investigations and technologies, and I'm just going to mention a couple of these in my very brief presentation. And all of this is trying to apply genomics into cardiovascular disease, and you can replace this with many different medical diseases, neurological diseases, gastroenterological diseases, etc., etc. It's the same principles of applying genomics to cardiovascular disease. Now, every one of the cardiovascular genetic conditions that we know of which there's at least 35 or 40 different conditions, all of them can lead to sudden death in a young person. And sadly, sudden death in somebody who's had no previous symptoms and present for the first time with sudden deaths. And you know, we all know these events happening, and this is a young soccer player, previously well, never had a problem in his life, on a particular day has a cardiac arrest on the field and is unable to be resuscitated. So what we did was we did a 3-year study looking at the causes of sudden death in young people, and you can see here that when a young person dies suddenly, almost half, 40%, there is no cause identified after a comprehensive post-mortem. So the mum and dad are left with no answers for why their son or daughter passed away, or the spouse doesn't know why their wife or husband passed away. Nearly 1 in 2 young deaths. So what we started to do, and I'm not going to go into details, but we developed the process called the molecular autopsy, which means in Australia and New Zealand it is now mandated that if a young person dies suddenly under the age of 40, a blood sample has to be collected and stored. That was work we did about 15 years ago to convince the government and the pathology services to keep that blood sample. And so we can do genetic testing on that blood sample to try and find the cause of why that young person died suddenly. And applying it to that 40% of people who are unexplained at post-mortem, we get a result, an answer in about a quarter of them. So at least we can tell the families why their son or daughter passed away, and we can use that genetic information not just to have some closure about why their child died, but to also use that information for other family members who might be at risk, like their siblings, like parents, like cousins, etc. And so we published this work in the New England Journal of Medicine, and it was a very collaborative project across a number of centres across the country. But research is interesting, and what we found was in the genetic analysis, if a heart is normal at post-mortem, we think it's an arrhythmic problem, a rhythm problem which you can't see at post-mortem. That makes sense. But what we also found was some cardiomyopathy genetic changes which were present in these deceased young people. So if it's a cardiomyopathy gene, the heart should be enlarged, the heart should be thickened, the heart should be abnormal, there should be a valvular problem, there should be something, but there's nothing at post-mortem, but they carry these cardiomyopathy gene variants. So this troubled us and tried to understand why this happens. And so now I'm going to tell you a story. This is a young man who's happy for us to talk about him. His name is James Medway. I'll need more than 5 minutes. I'll need at least another 7 minutes, please. I gave a long introduction, so, you know, about being upset and, you know, give me 2 minutes extra. This lady holding up 5 things. Okay, and they're going to need a lot more time to work out the winner because it's a complicated process. So let me tell you my story and then I'll finish. So this is a young man, James Medway. I never had met him before. And I got a call from Italy about 2 years ago about a young man. He's an elite rower. He was training for the World Championships and he was in a gym in Italy and had a cardiac arrest. Fortunately, he was quickly resuscitated, CPR immediately, defibrillator on his chest. In fact, the Italian rowing team was actually there and the doctor was there and saved his life, basically. He eventually came back to Australia, and what was interesting about this young man was we did every test under the sun. Cardiologists are great at doing tests. He had an ECG, an echocardiogram, an ultrasound of the heart, an MRI, an angiogram, an exercise test, a Holter monitor for 24 hours. Further monitoring, everything was negative. So no cause of why his sudden cardiac arrest occurred. But what we did was a genetic analysis and found that he carries a gene. You don't have to know the details, but this is a gene called desmoplakin, which in living people causes very severe cardiomyopathy and what we call arrhythmic cardiomyopathy and can lead to sudden death. So he carries a gene mutation which is potentially lethal, but he never knew about it because he never had a symptom. So we get an answer, and we've called this terminology concealed cardiomyopathy because he doesn't have thickening of the heart. He doesn't have an enlarged heart, but he carries a gene which can lead to a cardiac arrest. So what are we doing in the meantime? Well, Julia Spister, who's a cardiologist and a PhD student of mine in her final year, asked the question, well, is James Medway one of 1 million or one of 20 or one of 50? So we looked through all of our young cases of sudden cardiac arrest survival, and this occurs in 1 in 5 individuals. So 1 in 5 individuals who have a cardiac arrest who survive, you can't find anything clinically with them. And so genetic analysis is important, and this is the topic of an ideas grant which we put in, and so we now have a bit more money to try and investigate this further. So what else have we done? We've used the latest technologies. We've used the latest technologies to try and understand more about what are the genetic causes so we can do whole genome sequencing. So when I did my PhD in 1999, it took me 1 year to sequence one gene. We can now sequence every gene in a person's body, 22,000 genes in a few weeks. So it's amazing the advance in technology, and we're using that information, and a guy called Richard Bagnall in my group is spearheading that. And then the other thing, and this was touched on by one of the presenters earlier, is we can also develop models of these conditions in a dish. And this is really, really fascinating stuff, and this is what we call induced pluripotent stem cells. We take a blood sample from the patient, we take the white blood cells, we reprogram the cells to make them very immature, very early cells, and then we can make them into anything we want. So if we're interested in the neurological system, we make nerves. We're, of course, interested in the most important organ in the body, which is the heart. And so we make cardiomyocytes, as you can see here. And so Samantha Ross in my group, who's an amazing young researcher who actually did a PhD at Sydney University and just finished with no emendations, but halfway through her PhD wanted to do medicine as well, and so started medicine in a different university in Canberra, in Australian National University, and completed both and is now an intern. And what you can see in this slide is that she's been able to grow these cells, and you can see in the right-hand panel, the bottom lineage, the mesoderm, is the structure that leads to the development of the heart. So she can make, from a blood sample collected from a patient, cells which are cardiomyocytes in a dish containing the mutation that they have. And so you come into the lab the next day and this is what you see. So the cells come alive. So the cardiomyocytes which we were growing and growing, they start to communicate and they start to beat. So you have a beating dish of heart cells all collected from a blood sample from a patient, which we can now use for analysis and understanding of mechanisms of disease. And then Mira Holliday said, well, we've got to compare the disease gene mutations to a normal sequence. And so what she did was use CRISPR technology or genome editing to remove, I'm much happier with that, I'll finish in 2 minutes, which allows her to remove a particular genetic mutation causing disease. So for someone who's never seen a sequence before, where I've got an arrow here is where the mutation is in the patient. And then she can use genome editing to actually remove the mutation. And so it's gone. So we can now compare the disease sample of cells and beating cells with a control sample that doesn't carry the particular mutation. So these are the further investigations of concealed cardiomyopathy. We're going to do more clinical phenotyping, more genomic analysis, and look at more cellular changes. And I want to finish on this slide, which is a slide I showed you before, but I wanted to highlight one thing. In this particular report, it says the researchers at the University of Sydney, Centenary Institute and Royal Prince Alfred Hospital. We are blessed, absolutely blessed, to work in an environment where we can interact with so many experts in the field, and we can use the University of Sydney, a world-leading organisation, Royal Prince Alfred Hospital, and of course the Medical Research Institutes, of which I'm at the Centenary Institute, to combine our skills and to answer these questions, which always starts with the patient and ends hopefully with a better outcome. So I think it's a really important example. We heard about the Sydney Biomedical Accelerator, and this is a mini version of that in terms of the interaction between the hospital. I feel like I'm the luckiest person in the world because I wake up in the morning, which is always good. But I mean, to give an example of last Friday, I woke up, I came to work, I ran a clinic at the Genetic Heart Disease clinics at RPA in the morning. At 1 o'clock, I taught 190 medical students in the University of Sydney about genetic heart disease. And in the afternoon, I went back to my lab and talked to my students and planned some experiments. And the Rabbitohs won that night as well, which was great. So we're blessed in this environment, and I think we should, for the young people out there, to encourage you to make sure you don't sit in your own little organisation, but to interact with people at the hospital, at the university, and the relevant medical research institutes. And I thank you for your time and look forward to the outcomes of the judging.
That's fantastic. I promise I did not oversell him, did I? And that was a terrific presentation. And good to see that the stellar achievement doesn't stop with the head of your group and Dr. Sam Ross doing a PhD at ANU, doing medicine and her PhD. I think I've heard enough about her for the time being. Yeah, terrific work, and we look forward to hearing more of what comes from your research. Now, we are still waiting for the judges, but we have another terrific... Oh no, sorry, we're not waiting for the judges. Hello, can you play along and build the dramatic tension? Okay, just pretend to have some infighting. Before we reveal the decision by the judges, it's now my absolute pleasure to invite a few people up on stage to present the Sydney Research Awards and Scholarship Program. So I'm going to need quite a lot of help because there are a lot of awards and scholarships to give up. So Mr. Kyle Harvey, the Executive Director of Operations at the District. Yeah, let's give him a clap because it's no mean feat handing over a certificate and having your photo taken. So they've earned that. Keep that applause running for Dr. Stephen Hollings, Chief Executive Officer at the Heart Research Institute, and Christine Giles, Deputy Chair and Head Research and Education Committee at the District. Now, the Sydney Research Awards and Scholarships Program aim to recognise significant achievements and provide support to strengthen research capacity and capability across the region. This year is also the first year that we're introducing the new cardiovascular postgraduate scholarship, and that's why Stephen is here to present that award. And I think you want to say a few words about... Just a few words about that new scholarship program. So join me in welcoming Stephen Hollings again.
Thank you, and I do promise it'll be a few words. The Heart Research Institute was born out of RPA back in 1989. It was RPA clinicians who wanted an institute where they could do their cardiovascular research and bring on young people. And so, of course, the relationship with the Sydney Local Health District and Sydney Research is absolutely crucial to us. So when looking this year at how we could support Innovation Week, we thought the way to support it was clearly to support a young researcher who could come up in precisely this area and partner with the Sydney Local Health District and Sydney Research to do so. So the Heart Research Institute is very happy to support the Cardiovascular Postgraduate Scholarship, which we're going to announce the winner of today.
Yeah, do you want me to announce it?
No, I'm happy to announce it.
Oh,
if you
okay.
like.
Yes. Why not? Let's mess with the schedule.
No, you could announce it if you.
Okay, well, okay, I'll announce it because I've only got the one job. You know, I don't run an institute. So The recipient of the brand new cardiovascular postgraduate scholarship is, and I should explain what it does. It's designed to encourage and support students undertake a postgraduate qualification at Sydney Uni relating to research in the area of diagnosis, prevention or treatment of cardiovascular diseases. The scholarship, as we've heard, is sponsored by the Heart Research Institute and will provide up to $40,000 per year up to 3 consecutive years towards undertaking a PhD. So a very highly prized postgraduate scholarship, and the recipient of the inaugural scholarship is Mr. Niv Vijay. Okay, yeah, just soak up the moment. Take the long way around. That's great. And if we can just move more centre stagey so we can make sure we capture those photos. Fantastic. Yeah. And just lean it down a bit so you're not reflecting light into the cameraman's eyes. But you've had as many bad photos taken as I have. You know a thing or two. Yep. Beautiful. Oh, we're done? Yeah. Okay, congratulations. Thank you. Thanks very much, Niv. And I have to say, even though it's the first scholarship from the Institute, there was such outstanding nominations that the Heart Research Institute's decided to introduce a separate one-off emerging cardiovascular researcher education scholarship, which is very generous indeed. So the scholarship, the Emerging Researcher one, will provide $10,000 to support an individual to pursue educational opportunities in diagnosis, prevention or treatment of cardiovascular diseases. So congratulations to Dr. Sashika Ratwati. Well done. Did you two have a bit of a heads up because you were sitting conveniently close to the front of the room there? Well done. Congratulations. And thanks very much, Stephen. Kyle and Christine will stay here for the remaining. We've got 5 more awards to go. Everyone's a winner, but mainly just the award winners here this afternoon. Okay, so the next award is the Annual Health Research Infrastructure Award, which aims to recognise an individual with high research potential in basic science research and provide funds to assist with the purchase, installation, maintenance and hire or lease of equipment costs associated with a basic science research project. And the recipient of the Infrastructure Award is Dr. Joe Mates. Who you will recognise from one of Chris Semserian's slides a little earlier. So, no, it wasn't Chris's slide. It was Anthony's slide. Well done. Yes, you're featuring highly today. Well done. Congratulations, Joe. Well done. The Clinician Researcher Scholarship is designed to encourage clinicians seeking to pursue a clinical research career and offer support to provide funds for dedicated research time. And our recipient for this scholarship is Min Jiat Tang. Congratulations, Min. Oh, yeah. Rocking the elbows. Haven't seen that in a while. Yeah. And then he goes in for the hug. Honestly, where's the consistency? Beautiful. Well done. Congratulations. The Health Informatics Research Scholarship is next. It aims to encourage research into how clinicians, academics and researchers can work with health information and communication technology to improve delivery of care and outcomes for patients. And our recipient, Daniel Babakui. Well done. Oh, what was that? Did I?
Very close on the last.
Oh, very close. Can I have a little top up?
Barbecue.
Babacule, I'm very sorry. Daniel Babacule. Yeah, Daniel Babacule. Thank you. Congratulations, Daniel. 3 more awards to go. The Research Excellence Award recognises the best publication in a high-impact journal, and that goes to Professor Richard Scolyer, Associate Professor Alexander Menzies, and Professor Georgina Long. Only Professor Scolyer is able to attend this afternoon, so congratulations. Thank you. You know, you can photocopy it and get frames at IKEA, and that way everyone will get one. Yeah. Yeah. Okay, just tip from old player. Yeah. Congratulations. The Research Supervisor Award recognises the outstanding achievements of a research supervisor, and today that is going to Professor Kathy Sherrington. Congratulations, Kathy. Beautiful. Congratulations. And our final award is the Young Researcher Award, which recognises outstanding performance for early career research, and that can be up to 5 years post-PhD. And our recipient for the Young Researcher Award is Dr. Rebecca Ahmed, who is joining us via Zoom. Congratulations, Rebecca. Would you like to? Yeah, no need to make a speech, that's fine. But congratulations, well done you. It was a hefty lot of competition, and this will be in the post, so keep an eye out for it. Congratulations. Thank you. Thanks so much, Kyle and Christine. And now we've teased you long enough. It is time to reveal the winner of the big idea for 2022. So I'd like to welcome to the stage Dr. Andrew Hallahan and Professor Robin Ward to present the awards and oversized cheques, which are totally cashable in another form. Thank you. So it says here Bernie Hobbs announced the winner, but I wasn't one of the judges, so I need someone to whisper it in my ear. Or maybe you would like to announce the winner, Andrew.
So
Robin.
It's our pleasure to say that Dr. Joseph Dusseldorp and his group, with their amazing work on treatment of spasticity, have been selected as the winner by the panel. Congratulations.
Wow. Congratulations. Yes, there's a lot to hold on to, but I think you're totally up to the challenge this afternoon. Congratulations. Sorry for that little bit of mix-up there. And Joseph, I think it will be a huge relief to the rest of your family that finally you've achieved something, because your big sister is Marta Dusseldorp, so you're just like that other guy who hasn't really gotten much done. You know, Janet King is in your family, so congratulations, you. Did you want to say anything? You've got 5 minutes. No, I'm kidding. Congratulations, that is absolutely fantastic. $45,000. $25,000 in-kind support in the technology, and also from Cicada. So it's just absolutely brilliant. Congratulations. And I would also now like to announce the winner. Maybe you would like to announce the winner of the People's Choice. We had over 296 people voting, and the winner of the People's Choice Award is, Robin?
Is Dr. Sam Dowland for his work on the contraception.
Woo! Congratulations. $5,000. Any thoughts on what you're going to spend it on, Sam? Lots of hydrogel, lots of hydrogel. It's a very good idea. All right, well, congratulations. And congratulations once again to all of our finalists. You all did fantastic presentations, great pictures. Every one of you would be a deserving winner, but congratulations especially to our two recipients this afternoon. Thank you very much, Robin and Andrew. Andrew, you're sticking around. Oh yes, because you're going to do something, that's right. Yeah, it's been a long afternoon. If you can just wait there, like without being bothered by me for a moment. On behalf of the Sydney Local Health District Chief Executive, Dr. Teresa Anderson, and the Chair of the Board, Dr. John Ajaka, we would like to thank event sponsors. So we should have a PowerPoint with all of our sponsors up there. Yes, there they are. And the Hyatt Regency for hosting us, all of today's speakers and presenters. The panel members and everyone for coming. And I just noticed that actually you were meant to speak before I did that. So Andrew, please come over here and close the big idea seamlessly, like no one ever stuffed that up. Yeah, okay. Thanks, Andrew.
Oh, wow. I'm just so amazingly privileged to be here in front of such a fabulous audience. I am so sorry that I'm not Teresa, but I'll do my best. It's a great event. It's the first time I've been here. It is amazing. I'm glad we've been able to recognise those who've gone above and beyond. We've had a difficult couple of years, and now we're getting back to what we really love. So thank you all for being here. Thank you for those who did those 5 amazing pictures. My panel really loved judging it. We felt very privileged to go from back in time and skin healing to think about a universal venom antidote, to consider limb-based to really help those who suffer from that chronic swelling, the non-hormonal contraceptive to revolutionise women's reproductive health. We really had a hard time picking between that and also the anti-spasticity microimplants. So well done, all of you. Well done. It was just inspirational. So we can see the level of innovation, we can see the level of drive in the district. We know we have done much, that we have much to do, and it's just a privilege to support it. Thanks to my terrific panel members. It was great being a team with you. Thank you so much. Thank you to Bernie. You have chaired this masterfully. So, and thank you to all our sponsors who made this possible. It is actually, the sponsorship is very meaningful, and it does make it possible. And thank you for all being part of such a great community.
Yay. Thanks so much, Andrew. Thank you so much, Andrew, the judges and our presenters, and all of our presenters again this afternoon. And before I do the final wrap, I also want to thank the staff who have put these last 2 segments together. So for the clinical research team, Louise Ford and Davina Tang in particular have just done a ridiculous amount of work to get together that fantastic session. And for the big ideas, Penny and Davina, congratulations, exceptional work. Now tomorrow, you'll all be back in the Hyatt Regency for day 2 of the Innovation and Research Symposium. And again, we'll have a focus on connection, collaboration and dreaming big for the future. But really take the time now to celebrate the results from this afternoon's big idea and join us all for the symposium welcome evening, the aforementioned cocktail event, I think. So congratulations, thank you very much. Big ups for all of our speakers and recipients. It's been an absolute pleasure. Thank you for all of the work you do. We really appreciate it. Thank you.